Morning to all. My name is Gege Gatt. I am the CEO of EBO, and it's a pleasure to be with you all here today. I'm sure it's quite clear that the next 10 years are going to be really interesting for the NHS and rather critical. And this research from last year shows us the scale of the issue. We have 1 in 4 citizens who don't believe that the NHS can care for them properly. The good news is that research we have shows us where the main issue is. And this research is from a patient survey last year, in January 2022. And by looking at the red and orange bars, you could get a sense of where the issue lies, right? It's a mix of communication issues and access barriers. And we are privileged at EBO to be focusing on these 2 very specific problems, right? Access and demand. So those who are most in need of healthcare services are often excluded, particularly because trusts have raced to digitize their processes, creating a very high bar for participation, whereby the literacy levels that we require today are far more than citizens actually have. The research you'll see in the pie chart shows that around 1/3 of all adults are not sufficiently digitally literate to access or utilize any of the digital services which are available from the NHS. We need to solve that, right? And I believe, and I'll speak a little bit about this, that conversations, right, the most basic trick in the book, the most basic interaction stimulus, having a conversation is possibly the best way which patients should interact with trust. But how do you do that at scale, right? And that's where artificial intelligence comes in. The second problem that we focus on is the concept of the demand. A World Health Organization survey indicated that Europe will have 10 million less clinicians than it needs by the end of the decade to manage basic healthcare services. This is a problem because our academic networks cannot produce enough clinicians in time, and the only way we are going to be able to dent this issue is if we recognize which processes should be automated, which work can indeed be run through artificial intelligence, giving back time to our clinicians to focus on what really matters. And that is why we don't want to replace human clinicians, but we want to give them back time to care more for patients and automate those specific processes which are repetitive. And if you recall Patrick's slide from this morning, the 3rd most critical use case that he listed was the idea of operational artificial intelligence, not clinical, such as image diagnostics and so on, but operational AI, right? That which focuses through RPA and automation on engaging patients more deeply. So we want to help patients to easily access the NHS and navigate their pathways, but we also want to help the workforce within the NHS to take on a large volume of administrative work which they have on a daily basis, which if we free up and give back capacity, could change the institution. So with the right technology and some degree of cultural change within the NHS, I believe we can transform a lot of patient processes, making them ubiquitous. Our mission is to really encapsulate these key principles in where we want to see healthcare in 2030. So processes in the NHS, which are presently reactive, need to become more predictive through data. That which is presently inaccessible and overly complex needs to become accessible to all. That which is depersonalized needs to become friendly. It needs to become adapted to the need of the individual patients. That which is offline and siloed needs to be data rich. It needs to be contextually aware. That which is slow needs to shift to that which is real time, on demand, and immediate to a society which wants immediate gratification, immediate responses. That which is complicated, form-based, interminable fields and interminable self-assessments needs to shift to something which is conversational, natural, friendly, easy to interact with. That which is inconvenient should be convenient. It should be at your pace, at the patient, whatever channel you prefer. And that which is burdensome needs to become accessible everywhere. And that which is in one language, and therefore exclusionary by default, should be in any language and should be extremely inclusive. Why do we only do healthcare in a primary language when we have a social reality which is different from that? So our vision is utilizing AI to transform healthcare from a heroic, reactive, slow, and complicated approach to one which is routine, preemptive, fast, friendly, conversational. And equally important is the idea of patient empowerment. These conferences are great because they take an inward look at the NHS. But let's remember this concept of patient centricity. How do we restore patient agency by the end of this decade? And we know that this is a critical mission because by restoring agency, we will improve clinical outcomes. And this is what we have learned from our projects, right? Engagement is not about putting in another patient portal. Engagement is about having meaningful conversations with empathy, a word often forgotten in this setting, which is such a pity. And engagement is not simple. Patient engagement is not an easy task. It is about multi-stakeholder collaborative processes with measurable key outcomes where we can define and see success. Engagement is not automatic. It requires a trust to think about how do you build trust with that particular citizen. And engagement is certainly not about buying the next healthcare technology. It's really about building communication pathways that are meaningful and that are effective. So as an organization, I'd say this is probably what we do. We remove the necessity for this level of high digital literacy, and by doing so we enable access. And then we automate specific pathways through RPA to help meet the demands of today. So through the use of artificial intelligence, we typically look at changing the NHS to become more accessible, more personalized, more efficient. And essentially we work with trusts to define, iterate, and digitize a number of patient pathways. You could see 7 examples on screen, which are common use cases we focus on. So the AI engine essentially allows these complex business processes to be automated within a trust. For example, it identifies patients who have incomplete pre-assessment forms, preoperative forms. It reminds them to complete them through a conversation, and it would notify and escalate to staff members those specific patients who need additional attention or who require a reprioritization in their appointment. Of course, we are system agnostic, we are open by default, and so we have already integrated with a lot of PASs and EPRs out there. For example, we already read appointment information and can therefore help patients both predict when the next appointment should occur, but even help them organize new appointments trust-wide or even at an ICP level in one place. I think this can really transform healthcare. And here's how. Let me introduce you to these 3 characters who will be with you for the next couple of minutes. Harry, right? Harry is a grandfather. He's 58 years old. He's finding it difficult to cope. He's just lost his job. He's getting a divorce. And Mark. Mark is a psychologist. He works in a trust. And he's worked with EBO to digitize his IAPT patient pathway by combining an AI-based virtual assistant with common communication tools, right? SMSs, emails, QR codes, and so on. And Sally is our IAPT virtual assistant created by EBO. She works 24 hours. She's always learning in the background, very much like a human. And let me take you through what an automated pathway could look like. So Ebo's virtual assistant, Sally, reaches out to Harry. The trigger could be an SMS, which Harry receives, email, a link, a QR code, and a printed letter, which he receives at home. And she's pushing Harry to activate his GP referral. An appointment is automatically set, synchronized in the EPR. Sally will then guide Harry through 3 pre-assessment forms. But these are not forms. Sally is having a conversation with Harry. Harry can break the flow, can ask new questions, raise concerns. And of course, Sally answers these and helps Harry complete the entire flow. Mark, our NHS psychologist, is notified by Sally because Sally identified that within the conversations there are trigger points which require escalation. So she not only informs Mark, but also reprioritizes Harry's appointment. It should be done at the next available earlier slot. And because Sally can read the EPR or the pass, we could see which medical appointment slot is next available. Fourth, 48 hours before Harry's appointment, he receives a reminder and another conversation starts. Harry's going to ask, okay, what's the transport like? Do you have a disability ramp? Can I bring this person along or not? Do I need to bring any other clinical files with me? And of course, Sally knows those answers because she's been trained on millions of conversational models before, and so can give a sense to what the experience is going to be like. And through these 6 appointments that Harry will have with Mark, Sally keeps reminding him of the anxiety and depression score data which he needs to provide us, because we're not interested in pushing technology, we're interested in its impact and with its effectiveness over time. And the only way to measure success is through data. So Harry's condition is thankfully improving. All the data from this conversation is stored, normalized back into the patient record system, so a single source of truth. And then following discharge, Sally will signpost Harry to the right information and keeps following up with him regularly over a 3-month period. Of course, unlike the movie, Harry and Sally don't take a famous car ride from Chicago to New York, because Sally, of course, is virtual. And here are some of the more extensive projects which we're working on, and I thought I'd just bring them on screen just to give you a sense of some of these pathways which we're automating with different trusts, and give you a color for some of these. So in Somerset, we're managing around 1,000 automated conversations per month, and what's interesting is that 40% of all these conversations are happening outside of office hours, which is so interesting to show this cultural shift, whereby society don't want to interact during office hours, but feel that healthcare is something you manage often after 5 o'clock, right? But the patient feedback is really interesting here, because across the board, the patient satisfaction scores, we have a particular algorithm to work on that, are around 95% positive, right? Which is again showing this cultural shift towards a country that wants efficiency, that wants instant responses. In the 2 first flu vaccination campaigns, which we did for NHS Shropshire, the adoption rate was unbelievably 100%. We also registered 95% patient feedback. And I'll speak a little bit more about this specific case study because it's interesting. But I'd like to remind you of one of the slides that Patrick brought up at the beginning of this session today. And when he showed which AI technology is likely to be more ubiquitous and accepted now, it was NLP, natural language. That was the second most likely to be ubiquitous. And if you tie that back to what we're seeing here, it makes sense, right? Because understanding language and generating language efficiently is the most fundamental building block of society. Communication, and effective communication, is what drives positive outcomes. But do patients welcome automation? I think we need to stop and reflect on this, right? Well, from our projects, what we have learned is that adoption flourishes when patients are easily provided with the choice and not the obligation of using artificial intelligence. And this distinction is critical because choice helps us build trust between different actors in society. And that is the only route to technological empowerment. Citizens will use a tool because they trust it. And from the patient data that we have seen, and have now quite a large amount of big data there, what we see is that patients want a solution that's accessible, that's convenient, that's easy, that is immediate, and which just gets the job done. Of course, different patient cohorts will opt for different technologies and different communication solutions. Not everyone will want to use a virtual assistant. Not everyone will want to enter into a chat, a conversation with an AI instrument. And that's fine, because we need to give patients the choice on how to interact with their trust. And those that will choose digital will automatically release a huge amount of capacity and efficiency gains, which then can be reutilized for the benefit of all patients and staff. And here are some empirical results. So we started this AI-enabled appointment management solution with Somerset in 2021, and the outcomes have continued to improve literally month on month. So from a language recognition perspective, the Somerset virtual assistant has understood 99.2% of what patients threw at it. And believe me, the records there are very, very diverse, right? And language recognition is at the heart of AI. And for those of you who read Noam Chomsky, this is really one of the key points of AI's worth in society today. Patient adoption has doubled in 1 year. So by the end of 2021, we had 10% of the cohort which is using the tool. Now we have 20% in a full rollout environment. We have many thousands of fully formed, robust, end-to-end conversations between a patient and a virtual assistant, which reach a specific clinical goal, a measurable success benefit. But most importantly, from a patient perspective, 89% of all patients in this group actually say they're very satisfied with AI-driven engagement and its outcomes. So the interesting insights for me are these. Firstly, patients fed back to us that they want more processes to be automated. The most common reaction was, this is great, can we also do this, this, and this, and this, without having staff blocking that particular process? Can we automate more? Again, this shift in culture, right? Instant gratification. We're saving hundreds of hours of administrative time per week. And this result is increasing month on month. And here's a second example that you might consider. This is St. James. It's a private hospital. It's got about 200,000 outpatient bookings per annum. Gives you a bit of a sense of the size of the organization. I'm going to give 3 data points from this particular project. Firstly, you could see that 96% of all patients provided either a highly positive, like, or neutral sentiment to interacting with an AI tool. But let's look at some operation results. Within 6 months from launch, about 1/3 of all the contact center messages, all the contact center interactions were being automated through a virtual assistant. 12% of the entire booking activity is now done with no human intervention end to end, including any preclinical activities which need to occur before the patient can enter. That includes concepts like waiting well initiatives. We are seeing 10,000 automated end-to-end conversations per month which lead to a particular clinical goal. But perhaps more importantly, from a workforce perspective, we have reduced 28% of all the hospital's administrative workload, which now can go to focusing on really key critical elements. Another area which is interesting is this concept of peaks and troughs. as we've learned from the pandemic, what humans are not too good at is managing spikes. What AI is particularly good at is managing spikes in demand. So whether the demand multiplies by 30-fold tomorrow or dips by 60-fold tomorrow makes no difference, because the scalability of the solution helps us meet the fluctuation in demands. And I think from a perhaps psychological perspective, what I'm most proud of in this particular project is this concept of human handover. The workforce within St. James's has learned this concept that work doesn't simply mean working with other humans, but it means we are now a team which includes some AI elements, some supercomputing, and humans. And we know what work to hand over to each other. And this is the future of work. The future of work is about enabling these two key components to understand how to work together. And it is our role as technologists not to replace humans, but to help them understand how best to work with AI artifacts. And the third element of data are some verbatims from the patients that we registered. Okay, so let's conclude on finance, which needs to be one of the key considerations. So how the heck are we going to fund this, right? And you might think it sounds great, but of course the financial element needs to be considered. Well, we've taken our very first step in social responsibility and ESG, and we've created a fund which is called Skunkworks, which is our way of giving back. It's a 10 million innovation fund which we launched last December at a HET event, in which we will support the NHS to innovate at pace. Specifically, through this £10 million fund, we will support up to 20 new projects focusing on patient pathway automation by delivering true patient-first experiences. We will fund 70% of all the project costs through this fund to help us provide back artificial intelligence solutions to the NHS. This scheme is open to trusts and also ICSs. So if this is of interest, please do speak to us during the break. We'll be happy to give you a sense of how Skunkworks works. Most of our technology is put into practice quite quickly, mostly because all the work behind clinical safety and work has all been done before with other trusts. So often we see most organizations which go live with a low commitment deployment in a few months rather than a few years. But I think most importantly, you can digitize the front line safely. And this is a transformative experience. And it's interoperable. And it's outcome driven. So thank you all for listening. It's really great to be with you today. Thank you.